Obviously, everyone's heard what happened on Tuesday night, right? Phenomenal. The city is tingling. Even the president got it wrong. This is our second world championship, right? The Aces. And unfortunately, they had their big gala on Tuesday night. I don't know if anybody got a chance to go that over at Allegiant. And they were all watching the TV and not paying attention to the gala that was going on. But phenomenal game. I was very happy, and I told Wayne and a couple of people this morning, I couldn't watch it. My heart couldn't take it. I had to know that it was over before I could see anything, even though we went to the Aviators game that night, and everybody was yelling and screaming, and I wasn't sure what it was until it was 9-3, then I was happy. So God bless them. So one of the things that I always talk to people, what do you do on your summer vacations? Because a lot of the doctors we work with and the CEOs and stuff like that, they're always trying to figure out how do they get out, what do they do? A lot of people may or may not know, I love to ride motorcycles, I like adventure stuff. Donna, we were just talking about just not going to capital cities, doing something that's a little out of the ordinary. So I want to spend a couple minutes telling you, what did I do on my summer vacation about a week and a half ago? I rode my motorcycle from Anchorage to the Arctic Ocean. And to give you an idea of how beautiful it is, this is a wider picture of it. It was still late May, early June. So one of the things about the Arctic is that you never know what the weather is. It's kind of like when I lived in Reno. If you didn't like the weather, wait a minute, it would change. It really did. And so this was one of our days. That was one of our better days where the background, you can see there's very little snow on the ground. And then we turned to this. And all of a sudden we were riding in snow. And then sleet. And then what they call it Arctic sludge. And so to keep the ice road, if anybody ever watched the Ice Road Truckers series, this is where they ride on this road, and they mean it's the dangerous road. Not in America, that's more Nepal and Pakistan and India have some of the worst runs. But then I got off the bike one day and I said, this is one of our better roads. I was so darn happy. It was just ice and a few miles or a few hundred more miles to go that day, but it was just gorgeous. And then this was one of, unfortunately, on the way back, we got snowed out and we couldn't leave Dead Horse, which is the Arctic Ocean, to get back to Coldfoot, which is halfway between Arctic and Anchorage, and this is Adigan Pass. So if you ever watched the Ice Road Truckers, this is where they all had their problems or accidents. And we were coming down it, and we got snowed, and we had to make a decision. If we went about 15 to 20 more miles, we couldn't go back, and if we were snowed in, we couldn't go forward. So we had to make the determination to go back to the Arctic, and we did that. And the next day, the weather became even worse. But luckily, the snowplows decided to come out for us, and they gave us a little path to go. And then this is what we ended up with on one of the days. Just phenomenal, phenomenal Alaska. So if you haven't been, you got to go. And don't just go to Denali, even though it's beautiful. Go up north. Go to the Arctic, the Circle. It's just phenomenal. So with that, I'm going to go into our business side of it. The Nevada legislature. So Ernie asked me if I could talk a little on the Nevada legislative update, and then of course we'll talk about Silver State ACO and some of our things going on with our seniors, like myself. We had the three bills that were really the most important, AB 209, 404, and a little known one about AB 11. And that one really was going to cause a lot of controversy for us. So, but we'll talk about 209. 209 was the one that the lawyers are smart. You know, they're not dumb people. I don't like most of them, but they're not dumb people. They were going to put two bills together and say, let's test and see what people think of the first bill. And if we know that that bill can get passed, then the second one's going to make it a lot easier for us. If it doesn't get passed, we're going to know what your Nevada doctors, the Nevada State Medical Association, Nevada Hospital Association, we're going to know what their game plan is. What are they going to come after us with? And so by doing that, it was brilliant on their part. They went ahead and found out what we were going to go ahead and oppose, what we didn't like about it, and more importantly, for the few of us that were in the room back in 2003 when we had our medical crisis, when MICRA got implemented in the special session in 2004, it solved a lot of our problems. And obviously it capped, $50,000, the amount the attorneys can get. They had established a payment mechanism where the attorneys can get it scaled up till 35%. So there was a lot of things that happened in that. But they didn't get the traction that they expected, and it died in committee, so it never got to a floor vote. It just died in committee on tax day of April 15th. Now the big one comes up, AB 204, and we had talked earlier this year about how important that was for supporting the State Medical Association and the Nevada Hospital Association. What can we do to make sure this one doesn't even get onto a vote? Well, they use this little known rule, which I hate, which is called the waiver process. So as you know, in the legislation, when we have our 120 days, bill drafts have to be done at a certain date, and committees have to be assigned, and it has to be heard. Otherwise, they cannot go forward. But there is an exception, just like anything else in democracy, right? It's called the waiver process. So that waiver process gave them the opportunity to move this thing forward and keep it in committee, and then have no notice, and they were starting to have committee meetings. So it took all of April and May. Finally, the first week of June, they passed a smaller element of it. But we didn't get what we expected, which was just to kill the whole bill. But I think the outcome of it was positive. And the next slide we'll see how positive it was. But what it does is it takes the non-economic damages for malpractice and moves it from a cap of $350 that we've been at since 2004, and will increase it between now and 5 years to $750,000. So if you look at it from one point of view, from 2004 to today, that's not a huge thing, a little over 2.5–3% per year growth, but it does make it a little more attractive, that $400,000. But it's a stepped up process. So again, you're going to have an increase of about $80,000 a year. So what we're most worried about in the physician side of it, how much of a damage would this happen to your malpractice premiums? And that would be the issue. That would be, if it went from right to $750 immediately, you probably would have seen another 15 or 20%. This is going to slow that down, if not just pretty much flatten it out, we hope. After the 28th year, it can rise 2.1% or something to begin with the CPI, but no more than the 2.1%. So at least we have some relief on that. The statute of limitations one probably wasn't one to fight for, but the biggest one is to still have the date of injury 3 years. So it wasn't whether it was 1 year from notice to 2 years, but you still have 3 years. So that one didn't get changed, just they have now 2 years. By the time they know that there was something that went wrong, they now have an extra year to go ahead and get it into the system. And then this is the one that I'm actually surprised that, especially being that we have a Democratic Assembly, Democratic Senate, they say they're for the people. This is the one that hurt all the patients. They're going to lose their money to the lawyers. Now, again, I don't mind it. The money's getting paid out, right? So from the physician, from the hospital, you don't know where the money's going to go. In one sense, it's immaterial. But the attorneys are going to get a bigger bite of what gets paid out for the claim. And so you would have thought that would have been the thing, that if anything, if they wanted to say they're for the people, anybody, that's the one they would have said, no, we want more going to the hands of the injured person or the person that claimed that they had the malpractice against them. So that's a win for the attorneys. Now this is the one that we think is really a good deal, but it's only dependent upon this verbal agreement between the governor, the Speaker of the Assembly, Democrat, the Senate Majority Leader, Democrat, and then the stakeholders, which are all of you, that they're not going to come back for 10 years. So that's 5 legislative sessions. Now again, that's a governor that only has one more ability to be reelected one more time, so he'll be out of it. The other 2 will be term limited, so they'll be out of it. So a verbal agreement isn't worth squat. But you can only hope that they will pass on to their predecessors, whoever's going to follow them, that we did agree to this. And that the Trial Lawyers Association will agree that we did agree to this. But again, it's a verbal. We can only hope. But so even though they did gain some ground, they didn't make enough difference that I think it's going to make any real increase in our malpractice premiums, both at the healthcare hospital level and the surgical care facilities and the physician offices. That's the biggest win we're going to get out of this. Anybody have anything else on AB 404 that you could think of, that you've heard? No? Quiet crowd. All right. All right, so Medicare, I'll kind of go off of that, even though the A's did get signed yesterday. No, he hasn't signed it. It got passed by the Assembly yesterday and the Senate the day before. So I do expect, since Joe Lombardo was very much in favor of this, that's going to happen. And the memes are already out there. The A's will win a World Series in 5 years, right? So that'll be 2 years after they get here. So let's all hope and pray that if they do get here, that's going to happen. And of course, all the debacle that's going on Tropicana right now is completely going to be wiped on out, because that stadium is going to get built, and all this infrastructure they're building right now is going to be for naught. They're going to have to redo it. So just expect next 10 years you're not going to be able to get on Tropicana very easily. All right, so let's go to Medicare and ACO spending. So here's one of the things that I was trying to figure this out. In 2000, so obviously 3 years ago, the average CMS spending per beneficiary was $5,800. And it trailed up not so bad, about 1 or 2%, 3%, but here we are in 22, it's $15,700. So how do we sustain that? That's the problem. And especially if any of you read Becker's, yesterday, today, the CFO from United Health Group said that the spending is going to increase dramatically in these next 2 years, mostly because the people in the first 2 years ago, 3 years ago, weren't taking care of themselves during COVID. And now these ramifications from COVID are coming up. Hip replacement, joint replacements are on the rise, significant from their point of view. He expects that to go to closer to 19 or 20,000. So that's going to put more pressure on CMS to go into the HMO where they're somewhat capped. And the difference is huge, because as you'll see in our ACO spend, we spend more for fee-for-service than a managed care plan does. So the managed care plans have a much higher opportunity to curb some of this growth here, but what they can't curb is the amount of beneficiaries that are going into the system. So that's the problem. The baby boomers are hitting in stride here. But that's a pretty big thing, $10,000 in 21 years, 22 years. And the spending that's going on right now is, we're talking about trillions. This morning they talked about, we're currently in 22, we spent about $41 trillion, and it's supposed to go up to 60 trillion. It's not sustainable. So something's going to have to change, obviously, in our system. So again, looking at that, that would be a good if that's your revenue in your practice or at the hospital. But when that's the spend, then where's that money going to? And again, if you look at the hospitals right now, 50% of the hospitals in the first 6 months of this year probably are going to come out with a zero or a loss. And it's because all the other inflation, labor costs, supply chain, lack of supply chain. So even though the spend is going up, the costs are going to go up higher than the spend or the reimbursement. So we're going to have to kind of watch that. Then here's what we look at for the ACO. So we've been very, very fortunate. So here, the ACO benchmark, this is what Medicare says we should have been spending based on our prior year's population and use of services. And here's what the traditional non-ACO, non-HMO patients are spending. So we've looked at our trend, and this is us down here. We've not only been able to keep us below the traditional outside of an ACO compound, but even when all the ACOs in our benchmark, we've been able to spend below them. And then if we had time, I would have put another line. All ACOs are up here. So we are not only below the ACOs, we're below our benchmark. And so we do know the ACOs have an important role here in the state, and what they've done has been very, very healthy for the state. But that trend is what you're worrying about. If it keeps going up $16,000, $17,000, $18,000 per beneficiary per year, it's just not sustainable, and we don't know how we're going to be able to figure that out. All right, our Nevada beneficiaries, this is the one that kind of gets me a little interesting, and Bruce usually gives us a little report every year, and he goes onto the public documents to find this on out. But if you look at the number of Medicare beneficiaries in the state of Nevada, in 2013, we had 413,000 Medicare beneficiaries. So quite a large number, 2013, 10 years ago. And the amount of people that were in the traditional fee-for-service was 284,000. So it was 69% of the people stayed on fee-for-service. They didn't want to go into HMO. They didn't want to go over there. And as the costs have gone up, you'll see that for the first time in 2019, it really just completely flattened down out. And in 2020, it actually started a downward trend. So that in 22, the numbers aren't official, but it's very close to that. So in 21, we ended with a total of 561,000 people in the state of Nevada were on Medicare. And of those 561,000, 316 were on the traditional, 56%. So in that 10-year swing, it's gone from 69 to 56. We had just gone down about 1% per year for 8 years. Then it went 2%. But in 21, it went down 4%. Now, I think if the numbers are going to be close, we're about 49%. So for the first time in the state of Nevada, we have more people on the HMO product than we do on the fee-for-service product. So again, for those of you who are in that business side of it, the hospitals, it's not changing much of their stuff other than they've got to negotiate their rates. But on the physician side, you've got to be involved in the HMO business. You can't be outside of that. You know, a lot of practices, I don't want to deal with, you know, the major players, Humana, United, whoever, Optum, Aetna, all those people, you're going to have to, because that trend's going to continue. So from that trend in 1% per year to 4% to in 2 years, it looks like it's gone 8% down. And I expect we're going to probably end up in the next 3 years right around 60-40. 60% of those people are going to be in the HMO. And if you look at what the difference is, it's the retirement fund that they have been building up for all their career isn't equal to what their costs are anymore. So it's cheaper for the patient to be in an HMO setting. They don't have some of the, you know, costs that they need to have. If you want to go to fee-for-service, that's great. You want to have choice, that's great, but it's going to cost you. Now, even though they dropped the premium down a little bit, it's not enough to say that, you know, if I have a cost to share or if I want other services, the HMOs are going to be providing them. So I do ask all of our practices that we work with, you need to be involved with the HMO side. It's there, it's not going away, and it's getting stronger. And again, the numbers are going up, so we're well over 600,000 into 23 as far as the Medicare beneficiaries. And I guess as far as the way California keeps ruining themselves, we're going to get more of those people, and we're still getting more New Yorkers here. So between New York and California, we're getting a lot of retirees coming here. And Florida and Texas obviously has been a beneficiary, even though Louisiana for some reason is seeming to be a new hotspot for them. But if you've ever been there in the summer, it's not worth it. So this is a trend that we're going to see. And now how does that affect us at the ACO level? It does affect us because we have other people coming in here. And if there's less beneficiaries that are on the traditional, we know our numbers are going to drop unless we start bringing in some of the players that have tried to stay away from everything. You know, they think they're helping their practice by not being part of something like this, but it doesn't really help them in the long run. Big Brother is the one that's paying them. For some reason, they don't want Big Brother to know what they're doing, but they're the ones that pay them. So it's kind of a bad situation there. So what are we looking at? Ernie, I put this up at the last night, I shouldn't have. So Ernie then yesterday sent me a little list of things that I'm going to give you credit. He asked me to dumb this down as talking to him as a third grader. I know he made it through the sixth grade, so we're going to elevate that a little bit. Yeah. I didn't say he passed, but he got a completion certificate. So some of the questions that he asked me was really, what's the difference between an ACO and what is an ACO? Our ACO is really about dealing with fee-for-service Medicare, traditional Medicare, not HMO, not anything going with that. So we look at those patients that they have full choice, they can live anywhere, they can go anywhere, and the responsibility of the ACO is based on an attribution model. And so Medicare defines attribution as someone who's been seen more in a plurality by one provider than another provider. And based on that, they get assigned to that provider, and then that expense gets assigned to the ACO. So that's kind of the simple part of it. But it's only the fee-for-service Medicare. So we know we've been at 55,000 lives a few years ago, down to 35,000. Where did those 20,000 patients go? Some of them went into the HMO product, and others went into other models, like the ACO REACH, which is a more leaning to a full risk on the provider side and the REACH side. That's generally done by larger organizations like Intermountain, P3, Kano, Village MD. Those guys are doing national REACH programs. So they can share that expense versus an ACO in the state, like Silver State, we're just in Nevada. And I'm very happy to stay just in Nevada. So that's a big thing. How many ACOs do we have in Clark County? Well, right now we've got really Silver State and Prime. Those are the two big ones. There's 3 to 4 others that have national levels of ACO where they can join. So you can join an ACO in New Jersey right now, even though your population is here. A few years ago, you couldn't do that. It was all centered into where your geographic area was. Now they can share that cost and keep the cost here that's higher versus lower in, say, someplace in Ohio. And years before that, they could not do that. Now you can. So you're seeing some of these magnet companies are collecting up a lot of the smaller ACOs that weren't profitable, and they're trying to help them out by sharing that overhead. And again, I went back to we are the largest. We've always been the largest from day one, 2014. Renown is in Reno is the closest. They're at about 20,000 lives. I think 15,000 Prime here in Southern Nevada. But and obviously we've been the most profitable, not only in the state, but from a historical U.S., we've been in the top anywhere from 6 to 8 in profitability, and quite a few things that make up that profitability. It's not only our overall savings, but our quality scores. We started out at about 69 or 70%. 2 years ago, we went up to 96%. Was that the number, Rena? 96%. But every time they change their methodology, that changes our scoring. So again, it's we live based on what the Medicare is going to tell us how to work and how to live on that stuff. And from a national point of view, again, we've been in the top 10 for years. Hopefully this is June, so late August, early September, we're going to find out. All of our numbers say that this is going to be our 8th year in a row. And last year, when we were 7 years in a row that we made savings, that was only 19 ACOs in the United States that had done 7 years in a row. So the system is not designed to stay fluid. It's designed to have, I call it the EKG effect. You're going to do good, and then you're going to do bad. And the better you do, then your score goes lower, so you got to do even better. Well, you only can do so good. So when we talk about our savings at 15,000, we're at about 11, or not savings, the spend, we're at about 11,500. That's our number. So we're $4,000 less than Medicare is saying our spend should be or could be if we were not part of an organized unit. So that's a huge benefit to us. But a managed care system is closer to 8,000 or less. So we still have a lot of room to grow. But the difference is that they can tell you where you can go and they can authorize when you're going to get it. We can't. On the ACO, we just ask the patient and the doctor to work in conjunction with each other. Do you really need 3 MRIs? Well, one doctor ordered it, the other one didn't know about it, the other doctor orders it, he didn't read, the other 2 didn't like it, and he orders the third. There's where your cost of care is. It's duplication of services. Someone has all this workup done in the hospital, the physician office, by the time they see him, they don't even see it. Then they do it again. So we've got to figure out. Now, anybody in the room that's in the hospital side of it, it's a little different from my point of view, because when that patient gets admitted in the hospital, do everything. Do his teeth. Give him a bed check. Do whatever you can. Get everything done, because I've already sunk my cost into that admit. It's cost me $15,000 at the ACO level. So do every single test you can possibly do in the hospital that you have services for, so when they get discharged, we don't have to do anything and increase that cost of that care. That's not the right way the hospitals are going to look at it. It's just the right way I want to look at it from a very selfish point of view on the ACO level. And then PCPs. We've been driven from day one to be PCP oriented. So in other words, primary cares, your internal medicine and your family medicine, general medicine doctors. We want them running our organization because they do see the bulk of the patients. We do have four groups in it, and we have 55 independent tax ID numbers right now. We have 3 cardiology groups and an orthopedic group. Why did we decide to go that way? Because the 3 cardiology groups had influence, so they could help us bring people on in that they were talking to, and they knew who were the referrals. But traditionally, they don't represent anything from our lives point of view. I mean, 2%. It's just a very small, negligible number. A lot of other ACOs, and when St. Rose did theirs, they were dominated by the specialty. And that's why they never made any money. Because the focus shouldn't have been on the specialist, it should have been on the primary care who deals with the patient on every aspect of their care. And so those models have traditionally failed. The bigger systems that have gone to REACH and this other model where they have all that risk, the reason they can get away with it because they have every specialty covered. Whether it's a Geisinger, a Mayo Clinic, a UC San Diego, that's already what they have built into their system. They've got everything from ortho to oncology to geology. Well, they probably have that too. They got all the software and all the bells and whistles, but they've got an encapsulated group of providers that can do probably 80 to 90% of all the care. So they'll take that risk, and eventually they'll move that to an HMO model. And Rena and Bruce, when we first we're talking about this, we always believed that was the intent of Medicare anyhow. Get us involved with coordinating care and seeing the cost of that care that an HMO is already known, and eventually then force us to move ourselves into an HMO product. But now here we are going on 9 years, 10 years, we know that's not plausible to do. The financial cost and the burden for an ACO to put us into an HMO model is too expensive. But we do think we have one more full year, 24, in our 3rd agreement with Medicare, which is this 5-year agreement. And then we've got to decide what 26 is going to look like. So we'll be looking at that later this year and early next year. But all intents from what we've had with direct communication with CMS is that's going to stay in play. The way the ACO looks today is going to change a little. The REACH isn't plausible for a lot of the ACO members. So out of the 419 or 465, what is the number? 475. So we know a lot of them are going to go away, but most of them cannot go and afford to go to a REACH or to a risk. So we're still going to be in play. It just, how is it going to morph a little? And then what does ACO and CMS do as a team? Not a lot. It's kind of like the dad telling the 5-year-old, you're going to do this, and then we're screaming and kicking saying we don't want to do it that way. That's kind of our relationship with CMS. They're the father, the mother, they're the director. Whatever they say we eventually have to do, we just got to figure out, can we do it better than what they thought we could do? And it's a game. It purely is a game. And it's a very expensive game if we do it wrong, but it is a game. So we're constantly harassing them, saying, look, at what you're asking us to do is just stupid. You're forcing a provider to give someone information that's not even under your perusal. So, a couple years ago, they wanted every single practice to give us every bit of their data so that we could share that with Medicare. Well, why would a practice want to do that? Why would Medicare want to do it? Because they really want to know everything about your business, right? And all they have access to is what they pay you. They want to know what everybody else paid you. So again, if you think about where their direction is going, it has got some logic to it, albeit, they've probably been smoking to something that they shouldn't have. But the logic is they're trying to find out, can we ever go to an all-payer system? And if we know what everybody else is being reimbursed, we can get closer to something like that. But the states that have done it, Massachusetts, it hasn't fared well. It's not an all-for-one, one-for-all system. And for those of you who have traveled around the world, or like my clinic in Mexico, there's 5 different plans in Mexico. Everyone thinks Mexico is free. You go down there, you get health care because you're a Mexican citizen. That's a mess of crap. You get the best care if you work for the federal government. Best care. They have the best hospitals, the best doctors, the best availability. Then, if you work for the state, that's a separate hospital, a separate health system, a separate set of doctors. Then you have the people that work. And the employer, like myself, we pay into that system, and they go to a third system, a tiered system. And then you got your uninsured, and then you got your people that just barter. So Europe is the same way. It's been that way for years. I worked for a company out of Germany years back ago that owned women's hospitals, which doesn't exist anymore. And I was shocked how many hospitals they were building in Europe and in Australia, because the people that wanted to get access, they couldn't get care. So they had to go to a private, or they had to fly out of the UK or fly out of the system, and they started building all these private facilities. Worked very well for them, obviously. So we still have to deal with what we have. I still think it's one of the best systems in the world, and I've been able to travel a lot, so I do know that. Probably not as much as Donna, but I've traveled enough to know that I would rather have my care here than anywhere else. But it's at a cost, you know, and that's going to stay with us. So what are our things that we have to do in the next 2 years? We have to get better at our reporting and better at our quality scores, because everything about where we're going to get reimbursed now is going to be moving into our quality metrics. Not things that we designed, but Medicare wants us to be able to have better utilization, better quality metrics, and so that becomes just a massive amount of more paperwork that luckily we've got systems that do a lot of that for us, but these metrics aren't necessarily the best metrics. It's just what they want us to be able to work towards. So then that brings us to really our harder part, is that how do we have that relationship with our specialist? Because again, we have 800 and something physicians totally in the state that are part of our ACO, but our specialists are really driving a lot of that extra care and cost. And so we have to work with them, with our primary carers. And even though they're not part of our ACO, we do have a preferred network, because we've seen that their spend has been better, or their return to work has been better. Well, they don't work necessarily, the patients, not the docs. But we've got to figure out a way to work with those specialists to say, what can we do that's going to be a little more innovative? Do you need to do the surgery in the hospital, or can you do it in an outpatient setting? And again, surgical centers, as you probably have, if you've read Becker's, if you've read any modern healthcare, you'll see that the surgery centers are the next growth in healthcare, mainly because the cost is somewhere between 15 and 20% less. And eventually the insurance companies are going to figure that out too. You would think they would have known that from day one, but they're so entrenched with getting rates from the hospital that if they pull their business out of the hospital, they'll probably end up having to have increased rates. So they've got to figure out where that matches between cost and contracting. And that's going to be a big play in this next year for all of us as well. And then again, specialists, that's where we want to go. We know we have to engage our specialists in a lot more than we have in the past that work with our PCPs. Questions? Oh, Doc?
Me?
Yeah.
What percent of that 600,000 lives is many-manys, or are many-manys?
Well, about 20%.
And do you think the value-based programs in the Medicaid will affect the Medicare?
Yes, we hope it will. Yeah.
What percent of your attributions go to specialists from the ACO?
What percentage of our
Attributions go to the specialists?
It's, I can tell you, between the four groups, it's about 1,600 lives out of the 35,000. It's nothing. Well, and if you think about the logic of it is that cardiologist sees a patient twice a year, maybe 3 times a year. Well, let's say the average cardiologist. All right. Somebody in a primary care, somebody 65 and older, you should be going quarterly whether you like it or not. So you should, right off the bat, you should be seeing primary care more than you're seeing a specialist. But then you have the cardiologist, the oncologist, pulmonologist. You have all these other people. They kind of piece and take away that, but it's only the one that has the plurality. So as you know, we've always promoted chronic care management. You do chronic care management at the PCP level, that's one visit every single month, or one process every single month. That's 12 times. You'll trump every other specialist. That's how you do that. Annual wellness visits, again, another way to get people in there. 4 years ago, when I turned 65, I went ahead and tested it out with one of our doctors in the ACO, and I went ahead and went to the annual wellness visits. I realized I didn't want to know about my health history. So I had to bring my wife, because I knew I didn't know any of those questions. And so those two had a great conversation, and I just sat there and gone, how many basal cells have I had? Shit, okay. I didn't realize I had 4 of them already. You know, I don't pay attention to that. So I'm a bad example of a good patient, right? Now, I'm a great example of a good patient for the ACO level because I don't spend any money on me, you know, because I don't go, you know, and probably that's the way I'm going to be the next 20 years or more, or whatever my life will span. But so those are ways that really the PCP should have always been in control. And, you know, of course, like myself in the 70s when I grew up, everything went through the specialist. When I moved to Nevada in late 81, 82, I was like, damn, this state is dominated by specialists. They control everything. They then send the patient back for the little sniffs and colds and stuff, and they're taking care of everything. That just didn't make any sense. But in the hospital side of it, I was like, great, we're getting all these admits, simple admits, good reimbursement, DRGs came in 83. Boom, man, this was a great way to do business. It wasn't sustainable. And we still haven't shifted. We're still very dominated, but not as much so on the specialty side. It still needs to be more primary care based. And again, the doctors that stay in that realm, even though we've got the bigger groups, you've got to be able to know what's going on. And you know, I think the last time I was here, we talked about there's a hospital in town. If they go to that hospital, we know there's going to be 6 specialists involved in that patient's care. It doesn't matter what they went into. You go to another hospital, they average 3. What's the difference? Well, they've got a great network with the hospitalist. That hospitalist has got his safe team that surrounds them and says, look, let's just make sure everything's right with that patient. That's not the right way to do business. The hospital actually can't control a lot of that. They probably could help, but they can't really control that.
I have one follow-up on that. So I don't understand how the MA's plans, some of the MA plans will partner with the ACOs, and if you have this whole other group like Village and other people that are doing their own ACO, so how does Humana or partner with the ACO? How does that relationship work?
Well, they don't, other than if they own the clinic, then the PC, the fee for service patients can go off on their direction. And so like when we brought in Intermountain Health, right? They had 12,000 lives, but you know they had 90,000 MA lives or 70,000 MA lives, but they brought in the fee for service business to us. So that way they could take it out. A primary care doctor can only be in one ACO. A specialist can be in as many as they want. So that's a big difference. A hospital can be in as many as they want. So because typically they don't get attribution. So that's the reason why they have that exception.
Is there anything else besides chronic care management that will help with that attribution? And if I'm asking too many questions for the non-primary cares, please let me know.
Any patient that has more than 2 or 3, you know, acute diagnoses, get them in there. I mean, one of the examples when
visit has to be
visit. It has to be visit directed. Yeah.
I know with cardiology, if they do like a pacemaker check, they bill that and that.
Correct.
So there's nothing else that primary care can do to beef up.
No, but like event monitoring and stuff like that, that's not counted toward that.
Event monitoring. Okay.
Yeah. So some of those Holters and stuff like that,
No.
yeah.
But CCM does.
Yeah, CCM does. Yeah. So that's your biggest way to do it. And you'll see more of that when you do your annual wellness visit. Because then you've got that time, that 25 to 45 minutes that you spend with that patient going over look, you got 4 acute diagnoses here. Let's get you on this. There's cardiac rehab that's coming in here, outpatient cardiac rehab, which is all telehealth. So as you know, telehealth kind of got really promoted under the COVID, but it's going to grow because a lot of people do realize that. And in our state, that's one of the things that you know, helped our rurals. One of the things we were looking at in our executive committee yesterday was this diagram on the social determinants of health. So we know CMS is really embedded into that. Access to care and, you know, availability of care. Well, the people who live in Elko or Winnemucca or any of these rural towns, you'll notice that you've got a few of the companies that have got vans, you know, like Nevada Health Centers and Southwest Medical. They got these coaches that are running out there and doing those cares. We talked yesterday at our executive committee, maybe we need to partner with somebody or get a coach because we do have lives out there. We got about 12%, 13% of our lives that are literally out in the rurals, but they see people in the major cities. So that's how the attribution has started. So we got to figure out, can we afford to buy a coach? I'll drive it, I've done that before. I just won't stay at a Holiday Inn so I can see the patient in the morning. But so we just got to figure out a way to get that social determinants. That's going to be our next biggest goal. How do we do that? Jerry?
You mentioned a bill in the legislature about how hospitals contract with physician groups and or own physician groups. What happened to that bill?
So that was the one I didn't talk a lot about. It got vetoed. So it got passed both House and Senate, and it got vetoed by Lombardo. He was not going to allow, so the bill originally, if you go back to late September last year, somehow Renown got on everyone's radar up in Reno, and they were pissed. So they wanted to have a bill that said, they're the big animal. So you and I both know how Sunrise was the dominant hospital here for decades, and they controlled anything. If you wanted to have something, it was going to go through Sunrise first. Renown is the big animal up there. They're the grill on everybody's back, and they were just wiping out contracts and wiping out a lot of the payers. So they decided to put a bill together to say hospitals should not be owning and managing and running medical group. It's a conflict of interest. It's limiting the availability of care and increasing the cost of care. Then all of a sudden, Renown used all their might and power. It got turned around to not-for-profit hospitals, which they are, all of our rurals are, St. Rose is, not-for-profit hospitals can own them, but for-profit hospitals couldn't. So then all of a sudden it went from a Renown problem to an HCA and a universal health problem. And then they used all of their might to say, this is just stupid. I mean, either you can or you can't. And so it did get passed by Assembly, did get passed by House. Lombardo, I think it was on Monday or Tuesday, vetoed it. So, and I don't know what the veto is, what he's done so far. It hasn't been really large, but if you look at this session compared to the last two sessions, this was a very good working session. There wasn't all this acrimony. There wasn't crap swinging all over in Carson City. That was brought out. There was a lot underneath, but not that was brought out. Before it was just all public. So now if Lombardo can have that happen in the 25 session, kudos for him. I mean, that because that's the last session he can control for sure. Then you have the election again. And if we're lucky, he will win that one. Then we'll have another 1 or 2 sessions reasonably good. But again, you got to get out and vote as not only healthcare people, but you just got to get your kids to vote. Like all 3 of my kids, I press on them. It does affect you. It's not going to affect mom and dad as much anymore, you know. But it affects you because what they're passing today is going to stay with us for 20 or 30 or 40 years. So, you know, you can't solve stupid, but you can at least vote. So let's see what we can do on that. Come on, guys. Diego's looking at me going, I've got a few more minutes. Well, Bruce, we've been waiting for this one.
How are you guys doing on the primary care? There's always one thing with Preston, the original days, on chronic care management, business and wellness. Are you seeing that going up?
Yes, it has been going up, which is good. And a couple providers, unfortunately, have kind of gone out of that market because there's other profitable things for them to get into. But we do see that going on up. Carson Medical Group, Carson Tahoe, have really, they've teamed up with the University of Utah, and they're paying a higher cost for it, but they know that's the beneficial to them. So the fact that those guys are willing to pay more for something that they could have got a little cheaper, they realize the benefit of it. And so we're trying to get more of that enacted directly. And we do think that it's going to continue to go on up. That was pretty easy for Bruce if you guys have been in this meetings before. Thank you, sir.
A little fondness, so to speak.
All right, thank you. Yes?
How well do you guys do with data transfer from the hospitals in terms of ADT data?
Yeah, so our data transfer, so statewide, we use a system called Experian. And so if you've ever wanted a credit score or whatever it is, so we get our data transfer from all the Valley Health Systems, HCA, Common Spirit, the 3 dignities we don't, Northern Nevada Medical Group, Sierra Medical, our Northern Nevada Hospital, Sierra Hospital, and we had discussions yesterday about St. Mary's. So from the major facilities, we get them. We've also been in touch with Healthy Nevada because they're getting it from everybody, but trying to get
From the hospital or from Experian?
No, Experian right to the hospital, or it goes from the hospital to Experian, and Experian then we get it from the hospital through that Experian interface.
And does that work well? You feel like
Extremely well. So if you happen to get hurt right now and you went to one of the hospitals, Summerlin is the closest right here, you would go to the registration desk, we would get ping within minutes to seconds that you're there. So what we do is we send our list of patients to Experian once a month. They put that in their system. And so if those patients hit anywhere in the United States, then we're notified of it. Okay. And then we have a program in Arcos. Where's Sadie? You guys are here. So, yeah. Huh? Well, Sadie's right there too. Come on, Rena. Stay with the game here. So they know that patient has then been admitted and then been discharged. And then what their job is to tell that patient, hey, you've been discharged, is everything okay? We need you to get to the doctor. You know, we want them to be seen at being discharged from the hospital. And I think the last statistics that Dr. Praveen, where is he? He's in here. Oh, there you are. It was like 6 or 7% of the patients that are seen by them or talked to them by them are going to get readmitted in 30 days or less. And then it's like 11 or 12% if they talk to them in 16 to 31 days. And it's 16% if they don't get communicated at all. They don't take that communication. So we know that the patient has to be forced into realizing they need after hospital care just to be sure that everything's okay.
So you get notified by Experian the patient's there, and then you send Arcos to see the patient in the hospital?
No, they get notified that they need, it's all telephonic at that point. Yeah. Then the hospital obviously knows that they're there. So they have a little blurb on their sheet or their computer system, no paper anymore, that says, hey, this is an ACO patient. So the discharge planners and all that stuff are supposed to then be able to be in contact with them. And another company called Dispatch Health, they work with them as well.
Larry, are you marketing for new members?
Every day. That's Rena's full job between now and July 31st. So our biggest problem in this right now is that the ones that don't want to be in it, just, you know, it's a roadblock.
So have you seen them drop off and you fill in the gap?
Yes. Yeah. So our biggest problem right now is that there's shockingly still a number of practices that don't have an EMR, and they cannot join us if they don't have electronic medical record. So they're taking a 5% decrease in payments from CMS right now because they don't have it, and they're probably losing another 4 to 5% because they didn't know they were losing 4 to 5%. So the problem is they just are afraid to go to electronic medical record.
What data do you get if you could know who to market to?
Okay, so luckily Care Journey, they publish this stuff. CMS publishes it. So we know every single doctor in the state, how much they've been paid, how many patients they were, that unique patients they were given. The problem is it's 3 years old. Yeah. So when we go to a doctor, we go, hey, would you like to join the practice? And he goes, yes, but I work for Southwest Medical. Oh, crap. Okay. Oh, I just got bought by, P3, So those are the problems that you would think CMS would help us on out. And like I said, it's the dad telling the child you got to do something, and the child saying, but Dad, I got a better idea. No, you're a child. You don't know shit, right? So we're constantly fighting, within the own system. If we could have direct access of anything that we wanted to query them to and keep all the patient information, the PHI, all that separate, we would probably have a better success rate. But it's just not in the cards. It's not going to happen. Great question, though. But can you believe it? If you go to your doctor now and they're still on paper, they better be a darn good doctor, because that's just scary that they're not on an electronic medical record right now. And there's still a few of us, me mostly, that wish Lotus was still around and not Excel, because I hate Excel. I loved Lotus, but I can't buy the program. Do we?
Can a doctor belong?
A specialist can, a primary care cannot. Yeah. That was one of the questions that you asked me.
They do turnover. You are losing people.
We're losing and gaining at the same time.
Why would you lose except for the paper?
Well, like last year, they're uncooperative. Hey, so part of the requirements are you got to let us in your office every month. We want physical interaction with your office. It could be the doctor, but we want physical access. We want to give you these gaps in care reports to tell you how are you producing compared to anybody else, or here's the things that you're not doing, and here are the patients you're not doing it to, that you should be as a physician, right, or provider. So if they won't let us in the office, why do we want to keep them in there? They could have a great quality score, but they're not being cooperative. So we want to look at it that way, in that respect. Yeah. Come on.
One more. So if the hospital cannot own groups, which it does in the state of Nevada.
It can, yes.
It can, but they just can't participate in the ACO.
No, they do.
Squash that the hospital.
Well, what they really wanted to do is just take the hospitals, and Northern Nevada Medical Group is owned by Universal. Las Vegas Medical Group is owned by Universal. HCA has, 21 Care Now centers. They wanted to just say you can't own them.
Oh, at all?
At all.
Oh,
So they were going to have to sell it, which if you had an extra few $1 million, you would have been able to buy it for nothing, right? Because they were going to be forced to sell it. And then you could just sit there and wait. Now I can buy it for next to nothing. Well, that didn't make any sense. And I'm sure even if it got it passed, and Lombardo, I don't think would have been dumb enough to sign it, but if he had signed it, it would have gone to the Supreme Court. Now it would have been held up in the Supreme Court of the state of Nevada for years. Because there's too much money involved and too much investments they put into those medical groups.
And do you think that'll ever affect the hospital's relationship with the ACO? Do you think that
No. I mean, UHS owns the majority of our system here, but as you know, it's physician run. We direct, we lead, but it's physician run. So there's only so much they can do.
Larry, I have a question. You mentioned that doctors, when you see like several doctors, they prescribe the same exams.
Right.
Aren't the doctors supposed to read the medical records prior to the
All right.
patient's visit?
So when you're 3 to 4 minute visit with your doctor, they're moving from there to 3 to 4 minutes, to there to 3 to 4 minutes. You could not imagine how many faxes the doctor gets on a daily basis, or they get something through the DM under their system. They barely have time to be able to see you and figure what's going on versus taking 15 minutes to read everything else. In a perfect world, that would be great. In a perfect world, it would be all on the HIE, one software, and you'd be able to go in there before you got in there, you'd be able to see everything that's happened in the last 30 to 90, 120 days on a patient, and then you wouldn't have to do that. But if you're a specialist, are you going to give a darn what the radiologist has done? You're not going to crack that chest on a patient that a radiologist says. I think that's what you see that word think, because he's not a cardiologist. Or the oncologist is not going to take the word of a lab that is sending it out to someplace else when they're going to have to make a life decision on what meds they're going to give to someone. They want it in their own lab where they know that quality of work is being done under their design. So time is our problem, and just the way in which data is collected. I mean, even in our ACO, we have 23 separate EMRs. So as Rhonda says, it's like herding cats. They're all going in different directions. Even if you have the same EMR name, you could be on a different level, different revision level. They don't talk to each other. So even though you can go to the bank, put in a card, charge it, and they can tell you whether you got money right now today. In healthcare, you can go to the doctor and you don't know what everyone else has done immediately. But I guarantee you they don't have the time to look at everything that's coming across their desk every day on every patient.
Larry, how many quality coordinators do you guys have these days?
9.
9.
So
You're in your office every month,
yeah, everybody. So every quality coordinator has approximately 4,000 patients that they're assigned to. So those are then grouped to the individual practices, but that gives us an opportunity. We only, out of those 35, 40,000 patients, CMS judges us only on what they audit, which is a very small portion of them. And so you could have a perfect doctor, that rare perfect doctor that has one patient that they get audited on that they didn't do something on the quality score, and that quality score for that doctor sucks. It's not a good system, but it's the system.
The care is supposed to be being driven from hospitals to ambulatory surgery centers. Why are the commercial payers so reluctant to contract this?
All right, so let's say you got 300,000 lives culinary, or they have 125,000 now, and you go to the coalition and say, look, I'm going to put that $125,000 in there, or 125,000 lives, and that is going to give me a rate that I'm going to get a per diem rate at the hospital level. If you take the amount of patients that are no longer going to go to that hospital and you reduce it, that hospital gave you a rate based on 125,000 and the expectation of how many visits they're going to get. Now they're going to get, say, 20% less. Well, they want to make that up. So that's why there's a resistance there. And there are some older people, I hate to always put myself in that category, that don't believe in outpatient centers. I mean, we had a clear example of that.
You know, in 2001, I wrote a policy at HPN that you cannot go to the hospital for an outpatient procedure that can be done at a surgery center. It's still there.
Yeah.
I think coroning might be an exception. I think most insurance companies make you go to a surgery center.
Well, actually, HPN is one of the biggest detractors of that, except for their own surgery centers. They won't allow cardiology procedures to be done at an outpatient level right now, which is dumb. You know, it's absolutely dumb. A patient needs an ablation, do it in an outpatient surgery center. Optum won't approve it because the medical directors who are not cardiologists don't understand that yet. So it's coming. It's like slow roll, and data, and through the pandemic is the first time we actually got a number of surgery centers that were given exceptions, the hospital without walls exceptions, and it's absolutely amazing the significant change and the care, the people that got disease, something happened in the hospital or they caught something, all those numbers just slid at the outpatient surgery center. They had better outcome, patients liked it, they walked 30, 40 feet from their car to the surgery center, and they got wheeled out and put in the car. It had nothing to do with 14 stories, a lot better care. The data proved that this was the right way to go. The insurance companies aren't catching up with that yet. It's going to happen. It's just slow.
What does the hospital put within HIE?
Cost, because it does cost them. So the original stakeholders, have stayed into it, but it costs them to send that data, and the HIE, it costs a lot of them a lot of money to run that data. Okay, we're over our time, but if you have any other questions, I'll stick around.